Welcome to the Zealous Podcast. I'm your host, Rocky Snyder. And before we get underway, just be sure to click that subscribe button if you're a regular listener or a first-time listener. Just get in on the fun. Also, follow us on Instagram at Rocky_Snyder. And this week, we've got Jessica Bento, physical therapist, on with us, and she is one of the presenters at this year's Perform Better Summits. 4 of them, actually. They'll be in Providence, Rhode Island, Chicago, Illinois. She'll be presenting at Orlando, Florida Summit, as well as Long Beach, California, coming up in June and the end of June into July, talking all about if loaded carries are actually hurting your training. Well, we're going to tap into that a little bit, but also about sandbag training, her background, and a whole lot more. Hope you enjoy. All right, for the listening audience tuning in, Jessica Bento, physical therapist. She's one of the Perform Better presenters over the last few years here. She's been presenting at places like Chicago and Long Beach. This year, it's going to be Orlando and Long Beach. Is that correct?
Yeah.
And let's just dive into that for a second. What are you going to be presenting on at Perform Better?
So the title is Are Carries Hurting Your Training? And we talk a little bit about loaded carries because they become very popular. But the goal is to really talk about the movement pattern of locomotion. So technically, we should be programming movement patterns over just parts. But when it comes to locomotion, when it comes to rotation, these are 2 movement patterns that people often misunderstand. They leave out of programming completely. So I'm going to dive into locomotion.
Oh, wow. I feel like I'm on Jerry Maguire. You had me at movement patterns. That's fantastic. So, yeah, because when it comes to like loaded carries, many of the times it is bilateral loaded in the case of like farmer's carry, which is important to some degree, but there's a lot of compression going on at the same time. And the fact that you're holding on with both arms it doesn't negate, but it doesn't take into consideration proper human locomotion in terms of arm swing, and then for that matter, spinal motion of flexion, extension, lateral flexion and rotation. Is that kind of where you're going with your talk a little bit?
Yeah, I mean, where it begins with is not everyone walks well, but then we go ahead and load them because loaded carries have become so popular. It's like the cure-all for anything. I've heard people say, you know what, if you just do loaded carries, you're going to be just fine. But my goal is to get people to really look at, does this individual walk well? Should we be loading them? Putting fitness on dysfunction. That's one of, Gray Cook's lines. Are we putting fitness on dysfunction? So that's a question I'm asking or posing during this presentation.
I love it because in our facility, all program design centers around an individual's resting posture. Where are they holding themselves against gravity? And then how do they take that resting posture and move through space? So we incorporate the elements of the entire gait cycle. And once you understand what every articulation should do through 3-dimensional space in that entire gait cycle, which is pretty amazing, we can use that as a means of, I won't say screening or assessment, but just comparing. So I'm curious now, how do you do that? Because I'm sure we have it different ways.
Yeah. So, and oftentimes, because we're not talking about this in the fitness industry per se, we don't talk about locomotion, but we want people to program it. So I think it's important to talk about what's involved with programming locomotion, and it's focusing on those qualities that make up gait. It doesn't necessarily have to look like gait. You don't have to just load people up and say, okay, I'm checking that box of locomotion. But I am going to go through screens for people. I don't expect people to assess or diagnose because, that's not in the scope of everyone's practice. But I think it's important that people understand what good gait looks like. But it's not just going to be your typical, okay, let's just watch someone walk and see what happens. We're looking at rotary stability. We're looking at balance. We're looking at all of those things. So I put together an easy screen for anyone to do. Obviously, clinicians have their own assessments and their own screens, but this was just what I look at when if I do online coaching clients or if I'm doing anything virtual. These are the things that I ask people to show me so I have a better idea of how they're moving. So that is something I'm going to touch on in the Perform Better presentation, is going over screens and then showing real life people, not my patients, regular people that would walk into any training facility and show what's going on with their gait and why they wouldn't be appropriate quite yet for something like loaded carries.
You're sounding like a sister from another mister. I mean, we're talking the same language. I love this. We're going down the same path. I look at bony structures and articulations when I kind of go through some form of initial assessment, for lack of better words, like how well does that pelvis move in sagittal plane, frontal, and transverse? And there's four movements. Tilting, whether we want to break it up into anterior, posterior tilt, translating in the frontal plane, or laterally tilting, hiking and dropping, whatever you might call it. And then, of course, rotating left and right in the transverse plane. And all of those they should appear somewhere within a person's locomotion pattern. So what are some things, without giving away the whole pony show here, but what's one of the things that you look for?
So we're particularly, I mean, when I did the screens, I'm looking at some things, ability to control posture, right? I'm looking at single leg balance. I'm looking at something like a bird dog screen just to see if they can do rotary stability. So we're looking at that pelvic control. We're looking at a lot of different things, like ankle mobility, foot stability, all of these things I'm going to go through and assess, or I shouldn't say assess, we're going to screen with individuals just to see if they're lacking, if this is something we need to work on. Because if someone can't do let's say a single leg balance test, which most people aren't even screening for, or, looking at, I'm not loading them and asking them to do carries. They don't have that stability. They don't have that balance. Someone can't do a body weight bird dog. They don't have that pelvic control. I'm not going to load them up and ask them to do carries. They're not going to benefit from it. I don't want people to think I'm bashing loaded carries, but the question is, are they going to thrive during this exercise? Is it appropriate for them? Because we're not having people do kettlebell swings if they don't have a good hip hinge. So this is very similar to think about it this way.
Yeah, I was thinking, we could exchange loaded carries for 250-pound bench press. There's you got to work up to certain things, and maybe we get the mechanics down before we start loading into it. So yeah, that makes complete sense to me. I'm curious, with, say, the single leg balance, it could be a structural component. Maybe there's some issues of ankle immobility, lumbar instability, whatever we want to call it. But what about the neurological component? What if it is coming from a visual inhibition or a degradation? What if it's more vestibular? What if we're talking somewhere in there? Do you kind of address that too, or how do you determine?
Yeah, I mean, so for me, if I'm doing this as a clinician, yes, I'm going to be looking at that. I'm going to see if there's issues going on with the vestibular system, if it's a neurological issue, things like that. For the sake of perform better, I'm not having people try to diagnose these things.
No.
But if they see that someone is struggling with something as simple as a single leg stance, obviously I want them to focus on things like that. I want them to work on pelvic control. I want them to work on single leg stance and balance. I want them to work on foot stability. If they can cover all of these things, they're really going to target a lot about what's going on without having to really diagnose. So that's not something I'm actually going to dive into, just because I think that's more of a clinical side when we're really trying to pinpoint the cause of something.
And within your scope of practice on your daily routine, are you a clinician? Do you get into that setting these days? Is it more along the lines of bridging that spectrum from release from surgical care on to strength conditioning? Where's your playground?
So I've been all over.
Nice.
I started sports orthopedics. So that was my big love to start with, was sports orthopedics. And then,
why? What happened?
What happened? Oh,
why?
Yeah, you get completely burnt out.
But what drove you into sports orthopedic? Were you an athlete?
Yeah, so I was an athlete. I was a high level swimmer. So I always, from the day, I started physical therapy school, I was like, I'm going to work with athletes, and then you find that sometimes it's not the easiest of clients to work with, but I was like, I'm always going to do orthopedics. That was something I always knew. So that's where I started. And then I kind of progressed into fall prevention, and then a little bit of neuro, and then, went full time with our company, but I've never stopped treating patients over the years. So I've always been an active clinician.
Okay. And your company being, go ahead, give us the name of it.
So I'm co-owner of Ultimate Sandbag Training, and then the director of education for DVRT Fitness. So we do functional training and corrective exercise all over the world. So that is kind of what we dove into, is more of the education.
Nice. Okay. You opened up the can right there when you said corrective exercise. How do you define that?
It's such a broad term, but I think it can be used in many ways. But for me, it's exercise that is going to address a problem. It's a solution to a problem that I see with somebody. And so that can be, a big range of things. Corrective exercise can be strength training. It can be mobility work. It can be stability work. It can be, a lot of different things. But for me, everything I do, if I'm trying to solve an issue with a patient or even a client, is corrective in nature.
Cool. Okay. And the ultimate end result that you're hoping for by utilizing corrective exercise is finish the quote.
Yeah.
Improvement.
Improvement. I'm not looking to fix someone 100%, but we're always looking to improve upon things.
How much do you take into consideration a person's history with injuries, surgeries, emotional well-being, any of those and more?
It's a big component of whether or not someone is going to find benefit in doing a lot of the work that I give them. So it really, like my husband, let's say, he's gone through 7 different spinal surgeries.
He's a collector.
Yes.
Very nice.
He's a collector. So obviously, I'm not looking to get him 100%. I'm never going to get him there. So we're looking to get to a tolerable level, whether that's with pain, whether that's with his ability to do things that he enjoys and his overall movement. So it really depends. I never tell anyone I'm going to get you 100%. And they appreciate that. I think oftentimes people go in saying, we're going to fix you. And that's the worst thing you can say to someone. We're going to get you better, but a lot of it's going to be up to that individual.
Yeah, I'm just wondering, like I call it like a timeline with people when it comes to issues in the tissues, chronic ailments, so to speak, whether it be low back pain, rotator cuff, runner's knee, it goes on, any of the itises, right? And typically there is something that happened before that happened that triggered a new way of moving, subconscious pattern to get away or to do the next best thing given the situation that they are now in. And that became a normalized pattern, which added more work to other areas that somewhere down the road, weeks, months, or years, or decades, created inflammation, wear, and tear. And now that's the place in which the primary complaint is being housed, but it isn't the cause. Do you know what I mean? Like, so you being a physical therapist, and this is where I kind of like, I love talking to physical therapists because I want to find out what camp they're sitting in. Are they going to be using the protocols for acute care on the chronic situation? Or have they bridged the gap with continuing education beyond their physical therapy degree to understand that protocol actually doesn't apply? So where are you with that?
Yeah. So, I mean, that's where people kind of get confused when they see things that I do, whether it's on social media or through some of the writing or the education, they get really confused, right? A shoulder exercise doesn't look like a shoulder exercise I give to someone doesn't look like a shoulder exercise. Same goes with a knee. If I give someone a knee exercise, it doesn't look like a knee exercise. And that's where people get so confused. They're like, well, how can this help? Because I take a much more integrative approach to things. Just because your knee hurts doesn't mean I'm going to address that knee joint. It may not be the cause, it might be a symptom. And I think that's, it's sad because I see physical therapists kind of just really focusing on the site of pain. And that's not going to get you the result that you need. You have to figure out why that area is hurting, what caused it, because most of the time knee pain, shoulder pain, back pain isn't because of that exact area. It can, of course, but most of the time it's an issue with an entire chain, an entire system. The entire kinetic chain can have issues with it. But I look at it as the entire body approach versus just those just those individual joints, muscles, things like that, which I keep seeing PTs over and over again. Try to isolate muscles, try to, really focus in on a specific joint without integrating the joint. And it's sad to see, but they're kind of still stuck.
So you stay away from blaming a specific muscle for all of their problems? Yeah. Really? So the glute medius is not the villain in your story?
That is my biggest pet peeve, is when people, I think, and Josh and I talk about this a lot, but when it's trendy now, right? You have to focus on the VMO, the glute med, now it's the tibialis anterior. Yesterday it was the adductors, and it's sad that we're kind of reverting back to bodybuilding. For a minute there, we were going pretty strong when it came to a more integrative approach, but now I just keep seeing, 10 ways to fire, the glute med, or 10 ways to, get your hip adductor to burn. And they're kind of missing the point. I like to say it's dysfunctional training if we try to isolate individual parts, because that is not how movement occurs. That's not how we move. And that's not the way we should be looking at the body.
Do you ever go that deep though? I mean, integrative, yes, but is there a moment where you're going, I got to get that joint to move in a specific manner, and then let's integrate it back up? So it's almost like an accordion where you're going in and out, or do you just stay into like, if we can get these joints to communicate with one another in this position, we're going to be good?
I'll start there first. I'll start with a more active approach, a more integrative approach, and see where we get. And 99% of the time it works, where I don't have to go in and target a specific joint. Usually when I do some isolated work or target specific joints, it's post-surgical, it's acute, there's a place for it, don't get me wrong. But when I'm dealing with people that are a little bit more chronic, they're further out from their injury or their surgery, I'm going to take that much more integrative approach.
Okay, so when did this all occur? When did this epiphany rain down and the skies opened up and sun shined upon you? Because I have this feeling it didn't happen right out the gate when you became a physical therapist. What enlightened you?
Yeah, so, and I think we talked about this a little bit. I was introduced to Gary Gray right when I graduated from PT school. So that was my first introduction to kind of a more movement-based approach versus an isolated, just one joint, one muscle type of thing. So to kind of really look at movement was through him. The issue was the application. So I thought it was, oh, this is awesome, this is great. And then the application, I was like, this is a little hard to apply. We don't have the right tools. We don't have, the ability to really apply this science to its full potential.
What do you mean?
So, I mean, it was difficult to train movement, right? Loaded movement. You can train movement easily without any load, but you can't really see a huge progress unless you add load or resistance upon the body. So that became difficult. You could do some things with the dumbbells, but just in general, it was really difficult to really train the sling systems and movement as a whole with the tools that we had. So enter in meeting Josh, right? So the ability to use a dynamic tool, like something like the Ultimate Sandbag, really gave us more opportunity to train movement. That was the focus of that tool, was creating that tool to systemize movement. So I was able to take what I learned from Gary Gray and apply it in a much more applicable way with using load and a variable resistance tool. So it was much easier to train movement at that point.
Got it. With the sandbags.
Sandbags, kettlebells, all these functional training tools that we didn't really have access to until later on. So that's really allowed me to kind of see, like, we can really start training movement and not, just taking a bodybuilding approach. So.
Yeah, you've mentioned bodybuilding now a couple of times, and we have that also kind of in common, our not aversion toward it, but seeing that there are limitations. And the whole premise of bodybuilding was really more of aesthetics than it was the functionality of the human frame, right? Of how the body moves. So what other things make you cringe?
I mean, I think social media in general makes me cringe. I wish we didn't have it. I think just the availability of information that comes from every single person out there, and some of it is just really, really bad. And then trying to push back and teach people. And I don't know if people really want to learn anymore. I think that's disheartening. And then, if you go against what everyone is saying, you look crazy, right? If I say you don't need more VMO, there's absolutely no research that says you need more VMO. People will push back because you've got people saying otherwise that have millions and millions of followers. So I think that's what makes me cringe the most.
Yeah, cringe, but we're on the fringe. I got to put that rhyme out there just because, yeah, I don't mind being on the fringe. I'll be one of those crazy guys. Oh, yeah, he keeps looking at my foot for whatever reason. Yeah, I'm good with that. Okay, Gary Gray, you mentioned Gray Institute. You've done a lot of his coursework, almost all of it. Of course, we were kind of joking before we hit the record button that we both have VCR tapes, but no VCRs to play them in anymore. That's when we started discovering Gary's work. What do you have a course that you would, aside from all of them, I imagine, but is there one in particular for like the young starting athletic trainer slash physical therapist slash strength coach that you would recommend when it comes to the Gray Institute?
Out of Gray's courses.
Yeah, like
I
chain
don't,
reaction, CAFS, the 3D maps.
I
Where
mean,
would you
I
go?
did chain reaction. That one was great. I enjoyed that. But
Cool.
I know all of his courses are amazing. So
And where are your eyes set these days in terms of continuing education? Because I know you are not satisfied with what you know. At least I'm guessing that.
yeah, I mean, a lot of it is kind of when I create our courses that we do together, a lot of it is just me diving into the current research. So we just did a 12-week low back course. And, it was finding what is current, what is the research saying about low back health. It's really kind of diving into what's out there and how can we apply the science. So that's typically what I do on my end is look at the research and then how do we apply this. And that's where we come up with new programs and new ways of looking at the body and movement.
Curious. So, what is the research saying about low back? Like, what are some of the standout things that have come to your attention?
Well, I know one of the common things is now that, everyone's like, you need more mobility, right? So you're talking about chronic low back pain, and that's not what the research says. Actually, with chronic low back pain, it's people have an instability, usually of one segment or two segments. So you're talking about they move too much, right? So you have to do loaded Jefferson curls and these things to get more mobility of your spine is just not true. It's really about learning how to create that stability. Teaching someone how to create that pelvic control as well. It becomes about those things. But I know you need more mobility is one of the most common things people talk about. And people get mad at, MRIs now, you don't need imaging. It doesn't mean anything, but, imaging is really, really helpful in understanding what's going on with someone and what they're going to be predisposed to. I think people get really mad when they see, oh, look, everyone has issues going on in their low back. Yes, but that means when you get grandma coming in, you probably shouldn't be doing 100-pound, deadlift with her because she's predisposed to having these issues. These are things that are really popular on social media, right? Just understanding really what this research means and how to understand it better. And I just think people get that wrong too often.
Oh, I hear you. So, when it comes to loading someone, what what are your criteria? I mean, you're not going to load everybody right away. There's some people that are can't handle the load of their own body, let alone anything added to it. So, how do you determine that?
So that depends. So I know everyone says you just shouldn't load dysfunction, right? But if that load can be feedback and help that individual perform the movement, then that's where I'm going to use it. So something like a body weight squat becomes difficult for people, right? They can't create that trunk stability, right? They don't know how to, use their feet or create that stability into the ground. So if I can use load, something like a press out squat or something like that, that gives them enough feedback and helps them create that stability, then I'm going to do that. I think oftentimes people just go, okay, I'm going to start with body weight, but that's not necessarily the case. If you can use load to give them more feedback, how to teach them how to move, then it's going to be appropriate. So it's really dependent upon the movement. It's dependent upon the person. But most of the time I am using load. It's just how I'm using it.
Nice. Okay, you were mentioning like mobility and people may need to be stable. Aren't we just talking about joint speed, like relative joint speed with one another? If you understand how the body is meant to move, say in a squat, and you watch this person and they are actually driving through their knees, in my mind, well, the knees are moving faster than they need to, hips aren't moving fast enough. Is that kind of how you, as in your mind, how do you watch a body? Because that's kind of, I almost blur my vision and kind of just get a sense of how they're moving. Where is there too little speed or movement? Where is there too much? Can I slow the fast area down? Can I speed up the slow area and so on? How do you do it?
Yeah, I just start from the ground up. So I'm looking at the foot, the ankle, then I'm going to look at the knee, the hip, and the trunk. So really quickly, right? I'm not going to, go super slow or ask them to go super slow. I'll have them do a few reps and then I'm looking at what's going on at each of these individual areas. Half the time, like let's say we're talking about a squat, half the time it's because people don't know how to use their feet. you've got everyone wedging heels and doing all of this stuff, but it really boils down to, can they create that stability at the foot? Do they have enough proximal stability at the trunk to create that movement? And I'm never going to wedge someone's heels because of that, because I can teach them how to squat appropriately without having to do it, because it's not really an ankle mobility issue. Sometimes it is, but most of the time, not an ankle mobility issue.
Motor control.
Yes.
Yeah. All right. So what gets you up in the morning? What jazzes you? Because you've been doing this, I'm going to guess like more than a couple of years. So, and you see the same bodies over and over. A lot of times you see the same symptoms manifesting in different bodies and so on. But what keeps you excited about what you do?
I think it's really just bringing education to people that want to learn, I should say, not just putting education out there. It's putting education out there for the people that really want to learn is what's exciting. And letting people know that the way that we're doing things, the way we teach movement, the way we load people, it's getting people better faster. And I think that's the key, is faster. Everyone always says, if they get mad at something I say or I post, they're like, well, it works for me. I said, well, it worked for me, 10 years ago, 15 years ago, but what if something works better? That's what we're trying to do, is do better, bring better information to people, better education, and let them see that just because something's different or new doesn't mean that, you can't do it, right? Everyone always says stick to the basics, or, it's never been, nothing's new anymore. But it is. So that's what gets me excited.
And public speaking, you're quite good at it. So is that something? I
absolutely hate public speaking.
You do not?
Yeah, Chris at Perform Better has been trying to get me to speak for years, and I've never really wanted to do it. I've always worked behind the scenes. Like, I've worked with Perform Better for 15 years now. So, I mean, I've just never really wanted to get out in front of people and speak. So the past couple of years, I've been doing a little bit more. So I don't know if I'll ever thoroughly enjoy it, but we'll see.
Way to get uncomfortable. Good for you. That just brings about change. All right. Well, I'm expecting you're better than Josh any day, but I'm just kidding. Just kidding. He's very good. Do you work with athletes in the Vegas area? Do they come into Vegas to see you all, or what's your average client that you work with? Is it general population, or what are we talking?
It ranges. So most of the people that find us are kind of, they've given up hope, and they've kind of been everywhere, worked with every single person under the sun. So it's all over the place. We were consulting with one of the top USA weightlifters. She's probably going to take gold at the next Olympics. So consulted with her for back pain. We've worked with people that have had major surgeries and have tried everything. So it just ranges from athletes to regular people to, you name it. It's really kind of just people that really want to get better and they don't know where else to go.
Right on. Okay. Can you just give me anecdotally a client who will remain nameless, like one of those moments where you're going, oh my gosh, this is so incredible, so amazing. Success story.
Yeah, I mean, it's usually clients that are in excruciating pain. It's the chronic pain patients where, I mean, you see huge change within a month or two, where they're like, I have very little pain. I can finally move. I can do things. I can finally exercise without pain. It's those clients that are just kind of like, wow, this works. Seeing someone like Josh, who should be, basically on disability. I don't think people realize the extent of his surgeries and what he went through. And to see him be able to train, travel, and speak is kind of a feat in and of itself. I think people see him and they don't realize, they're just like, oh, okay, he had a back surgery, but no, it was massive. So he's a testament to what we do. Nice.
And your facility is in the downtown area of Vegas?
No, we no longer have a facility. So we had a training facility in Phoenix. And then when we moved up here, we shut it down because we were traveling so much. So we no longer have an actual facility. So most of the people that come to us are, with virtual.
Well, that's just opened up your campus to wherever English is spoken, unless, do you speak a foreign language as well?
No, not good.
All right. Just enough to order dinner or something like that.
Right, yes.
So with your physical therapy background, I'm just kind of thinking about your path. And really the bottom line is you have never been satisfied with your level of knowledge, and you're continually investigating and looking into research. Are there places right now that you are educational companies, if you will, like that you're intrigued by, that you're investigating, kind of like Gray Institute back in the day? Are there other places that have have your attention?
I mean, I follow a lot of what Thomas Myers does. I've had the pleasure of meeting him. So obviously I look at a lot about his content. We take a lot of what he does, and we're the ones that apply the science through movement. He's even done a lot of our courses and gone through a lot of our training too. So that was actually interesting. But I mean, what we do is kind of different. So it's hard to say that people are on the same track. So there's no one that stands out that much to me.
Certainly. So in your own words, what makes you different?
I think the way that we just look at an integrated approach to movement, we have systemized movement. Someone, and just kind of give you an example, a typical person is going to look at a squat and say, I have 2 or 3 different squats, right? That's all I have in my toolbox. I can tell you I have a dozen different squat patterns. The same with a hinge. It's a way to look at movement in a very systemized way, but an incremental way as well. So our tools have been able to allow us to systemize movement. And I don't think you see that very often. Something like a sprinter stance, something like a max lunge, those things that have become really popular over time, they didn't exist before us. These are things that we came about with and protocols that we came about with. So I think people forget this stuff wasn't always around, and they forget where it began and where it started. So we've been able to do that in a way. And I think that's what allows us to get people better, because it's about the progressions or the regressions that we have available. If you only have 2 squats in your pocket, you don't know how to regress anyone. You don't know how to progress them appropriately.
Got it. Okay. So obviously, back in the day, the majority of lifts were sagittal plane bias, bilateral loading, and just by virtue of that, there was very limited amount of locomotion, because locomotion is a contralateral bipedal kind of action, right? So let's talk about unilateral, ipsilateral, and contralateral movements. Does that make up a large portion of your programming? And where does bilateral loading come into play with that too?
Yeah, I mean, just kind of give you an example. So I have an online client. She's had 2 total knee surgeries and lumbar surgery and a plethora of different things going on. So bilateral lifts for her aren't going to be great, because she's already got compensations from side to side. So she does very little bilateral lifts. So if I'm going to do a bilateral lift with her, I'm going to give her a little assistance. I'm going to elevate the implement. I'm going to give her some band feedback so she can eliminate as much compensation as possible. She's going to do more offset stance, sprinter stance, single leg stance, step ups, step downs, things like that, where she doesn't have that as much compensation from side to side. So it's really going to be dependent upon that individual. Someone like Josh, who's had multiple surgeries, not a lot of bilateral lifts because there's a lot of compensations going on. And I think people automatically default to a bilateral lift, thinking that it's the easiest for that person or that individual, not understanding that compensations can occur if you're actually working with people that have had chronic issues. So it is going to be dependent upon that person. I do lots of bilateral lift. I can tolerate it. I don't compensate during the movement, but obviously you have to progress outside of that. So that's when we start going into multiplanar training, right? We're moving in one plane, or we're resisting another plane. We've got load that we're resisting as well, so it can get rather complex.
I imagine that's the fun. That's the joy of cooking right there. You're creating recipes for success, truly. So yeah, bilateral lifts typically put a gag order on the spine, except in the sagittal plane. So you're going to be really reducing how much frontal and transverse action there is. But as soon as you lift one leg off the ground, everything changes. So with this also is revealed asymmetries. And this is also a term that has been over talked in certain ways, but just thinking about asymmetries in the case of a client slash patient of yours, they've got um, a side that doesn't produce as much force as the opposite side. Are you going to be a little bit more biased? Are you going to encourage them to do maybe a little bit more additional work on the side that is not as producing as much force as the other side? Or how do you address those issues?
So first, I'm going to find out why. Why are we having this much, different side to side, or that asymmetry that we talked about? Why is this happening? And then again, that might be someone that I'm probably not going to do a lot of bilateral lifts with, but I'm not the type to kind of go, you're going to do 15 reps on this bad side and you're only going to do 5 on this side. That's not how I would program. We're going to really address why there is this weakness in whichever system that we're finding. Usually it's most of the time people will have that lateral sling system weakness, one side versus the other, but it doesn't mean I'm just going to focus on that side. It'll mean that my program is going to be based upon that, right? So we're going to focus maybe on, let's just say if we're doing the lateral sling system, we're going to be focused on, maybe side planks, or we're going to do step downs, or we're going to do half kneeling positions and postures really to kind of get that a little bit better. But I wouldn't focus more on one side or the other.
Yeah, and thinking of that too, it's not spoken in every circle, but when it comes to, say, places that have limited mobility or places that have excess mobility, it could be that the unconscious mind, the unconscious portion of the brain that is responsible for these, this is their survival tactic. This is their way of preventing something else from occurring. So oftentimes we'll find somebody that comes in and they say, oh, I've been told to stretch my hamstrings because they are really, really locked up. And as soon as they do that, they've taken away their strategy for maintaining stability. So I know you've probably found that or have witnessed it yourself. So in your process, you must have to address that, but maybe it doesn't need to be addressed because of the process you've created. Can you give me a sense of that?
Yeah, it happens a lot. I mean, you say if you've got tight hip flexors, stretch, everyone's got tight this, tight that, stretch. I'm going to give you 10 stretches for your, psoas. I always ask why. Why is that psoas tight? Is it really tight? Is the hamstrings really tight? Usually it can stem back to a core stability problem most of the time. So as long as I kind of focus on pelvic control, core stability, oftentimes that fixes it. Obviously, if you have like a real injury, let's say to the hamstring or that quad or something, that's a different story. But I'm talking about just in general, someone walks in and they're like, I'm always tight, or I'm always, this always feels tight. It's usually stems at the core. That's why people kind of get confused, like, why is this a hip exercise? Why is this a shoulder exercise? Because usually it's a lack of stability. They don't know how to create it. There's some sort of disconnect there. So I start there and see where we can go. People always think it's like a magic trick, but I'll have them do, maybe a half kneeling around the world, do a straight leg raise, check it. 9 times out of 10, it improves. So that tells me it's a core stability issue most of the time. So I always try to find why they're having these issues, and that goes through lots of different assessments. But usually, if you start at the core, you're gonna find improvement.
Okay, so when it comes to progressing people through this process of improving core stability, do you begin in an upright position against gravity with all these joints having to coordinate with one another? Do you go at the other end of the spectrum where they're supine, and then we go prone, quadruped, kneeling, half kneeling, standing, and so on? Which end of the spectrum do you begin with typically, and what does that look like?
Yeah, it's really going to be dependent upon the person. So if they have no idea whatsoever how to create stability, let's say you're working with someone with a big history of chronic low back pain. Usually those are the people that just don't even know where their body's at in space, right? So obviously they're going to start in an easy position, whether that's supine, we're going to go through different dead bug progressions, or, that's actually, it can be difficult for people. People don't realize, getting in that position when you have chronic pain can be challenging. So it's really about finding the position that they're most comfortable in, and where they can actually learn what they're supposed to be. So whether it's going into that supine position or a 4-point where we're doing, bird dogs or side planks, or we get into that half kneeling and kneeling positions and postures, but it's kind of going to look like all of it combined. So you're going to see, so a warm up for an online coaching client might go from the floor all the way up to standing, right? A whole rehab program for someone might look like that. So it's just dependent upon that individual, really.
Nice. And just from your day-to-day or weekly client load, how many people do you typically see?
I try not to see that many. I have a full-time job with DVRT, so I usually see maybe 4 in-home local, and then I have about a dozen online consultations or people that I'm working with currently. So not that many.
That's nice. About 3 or 4 appointments a day if you're going Monday to Friday.
Yeah. So, I mean, I try to keep it as light as possible. I have a hard time saying no to people.
You and me both. I think that's one of our cruxes right there. You want to help as many people as possible, and yet you want to try and educate others to do the same. And there's only so much time in the day. What's your biggest challenge these days?
Oh, the biggest challenge, I guess, not being disappointed that people don't want to learn. I guess you can only put out so much information and hope that the people that really want to learn take it and learn from it. But I think realizing now that it's just kind of a lost art form. I think learning or fitness education is something that's not as popular as it was. So I think that's trying not to be disappointed and just kind of looking at the people that really appreciate what you put out there is important.
Yeah, that's the hard part about trying to come back in person with these conferences and summits and whatnot, is that so many of the trainers that came up during COVID, all they know is online education, and there's a plethora out there for better or worse. And there's something special about actually connecting, networking, and just being in a room with other like-minded individuals. The energy, it can't be replicated online. It's just no way. So we've got a couple more minutes here. The Perform Better Summits you're going to be presenting at, once again, they're Orlando, Florida, and Long Beach, California. Long Beach is June 30th to July 2nd. When's Orlando? Do you know off the top of your head?
Orlando is June 3rd, 4th. I might get the dates wrong, but I know it's the first weekend in June.
First one to kick, and the first of the 4 summits there. So for the listening audience that is not familiar with performbetter.com, they are premier equipment, I would say seller of major equipment in the strength conditioning and rehab world. But Chris Poyer, who is the CEO there, has gone above and beyond. He gets individuals like Jessica and Josh and others to come and give these amazing presentations where it's a lecture and then followed up with a hands-on, or vice versa, over the course of 2.5 days, continuing education, drinking from a fire hose. It's amazing. So Providence, Rhode Island, Chicago, Illinois being the other 2 locations. You can go online to performbetter.com and find out more. And then do you go to other organizations, other conferences and present? And if so, would you have any coming up on your calendar? I could check you out. Check out your presentation.
So I've done NSCA and NASM in the past. We of course at DVRT have our own certifications and workshops that we teach all over. The biggest one coming up is in Tokyo. I don't know if anyone wants to come to that one. We are doing a pre-conference of our progressive kettlebell movement cert, and then after that I'll be talking again about locomotion and low back pain. So that's our next biggest one outside of the Perform Better Summits coming up. But
fantastic. And of course, the NSCA National Conference, that's going to be in your backyard there in Vegas, middle of July.
I'm not speaking at that one this year.
Oh, all right. Will you be in the halls?
Probably not.
Dang. All right.
Down on the strip. I try not to go down there.
I guess we'll just have to connect in Long Beach. I'll bring an extra surfboard just in case you want to go out early morning and get out in the water, because it's always a better way of learning when you get a little saltwater plunge before the first Perform Better presenter goes off. If we want to get more information, this is the time to put it out there, Jessica. If we want more information about yourself, we want to follow you on social media, which I have a feeling you don't do much of, but and your websites and any course information, how we can follow you. What do we do?
I actually do put out a lot of content regularly and consistently. So the majority of the education is in a lot of the write-ups, which, you know, you can find beneficial. So I'm just Bento, physiotherapist, for Instagram. Our website is dvrtfitness.com. And then we do have a restoration and level 1 course coming up in October, but I won't be teaching it, but that's on our site as well. So that one will be in La Crosse, Wisconsin. So that's our next local event.
Fantastic. You say physiotherapist. That's a very European way of thinking of things. I'm just curious. You didn't say physical therapist. Is there some type of line of demarcation between the two, or are you just like that title?
I think I went to school with a lot of Canadians, so that might be where it came from. I don't know. Or just to be different. One of the two.
I like it. Well, you are very different from many of the physical therapists that have come across, and it's refreshing, to be honest. Not to say anything negatively about the industry in any way, but where you're going, it sure is a bright light. So if I will put the links in the description below the podcast. In the meantime, Jessica, thank you for your time. This has been wonderful. And I look forward to connecting, hopefully, with you and Perform Better's Long Beach Summit. Well, that's another episode of the Zealous Podcast. Thank you, Jessica, for coming on. And be sure to check out performbetter.com for their training summits. It's the who's who of presenters, all in rehab, fitness, conditioning, in and out of that industry. They do a remarkable job. Just go on, click on register, and join in. Get some networking, in-person education and information. Connect with the leaders that are in the field. Hope to see you there.